All right, welcome again. I'm Dr. Amanda Smith, an Education Work Group co-chair for the Watch Coalition. Thank you for joining us at our virtual Watch Wellness Workshop. And thank you for taking the time to register when logging in to Zoom this morning. That's how we're able to capture attendance. We're going to get started here in just a minute. If you haven't already done so, please share your name, the organization you're with, and the primary population you serve in the chat box for networking purposes. We'll get started here in just a second. So please be aware that this session will be recorded and made available through website and social media links to inform and educate the public on this topic. Throughout today's program, our speakers may ask you to raise your hand to ask questions, and then they can unmute you, or you're welcome to ask questions in the chat box as well. So keeping in mind that if you choose to participate in an identifiable way, you acknowledge that your name will be recorded and you're authorizing the use of your information in the recording as described. So the recording of today's workshop is protected by copyright law and is not to be copied. I think we are ready to roll here. So welcome on behalf of the Wellness Alliance for Total Children's Health of Denton County, or WATCH. I'm Dr. Amanda Smith, again, still an Education Work Group co-chair for the WATCH Coalition. It's our goal to work together to organize opportunities for professionals and community members to learn about specific topics related to children's mental health and to learn about the resources available in our community. We have many people to thank for working collaboratively to put this event together. We'd like to thank the members of the WATCH Coalition for planning and thinking through our program, Cook Children's for providing the free CEUs, and you. If you've attended our previous events, thank you for providing feedback. We've planned this program with you in mind. We always take previous feedback into account when planning upcoming workshops. So we'd also like to thank each of our speakers for giving their time and sharing their expertise with us today. With their permission, we'll post the slides from today in the Center for Community Health website. Those should also be available in the packet that was emailed to you. So again, we invite you to engage with the speakers and other attendees in the chat box, or you can raise your hand and the speakers will be able to unmute you, since we're having a slightly different format for the workshop today. So in the chat box, you can talk to the group as a whole or one-on-one by clicking on the button next to the To field in the chat feature. This is located just above where you type your message. We'll also keep the event open for 15 minutes after the event, from 2 to 2:15, so you can continue networking, ask additional questions, and share information about your organization in the chat box. So today, we will be discussing substance use, cultivating support strategies for children and youth. We will learn about current trends on substance use from a legal perspective, reasons for use, treatment and interventions, and finally, we'll have a panel discussion with our speakers about creating a trauma-informed culture of unconditional support. An evaluation link for today's event will be shared at the end of the program. All are encouraged to complete the evaluation, and it is required to receive continuing education credit. Again, and we do use that feedback in planning future workshops, so it is really important to us, and we value your input. So for your convenience, we've created an event packet for you to use as you follow along with today's presentations. You should have received an email with a link to the event packet. If you did not receive this, please let us know in the chat and include your email and we can send it to you. But again, go back and check in your mailbox, look in the spam folder, just to see if that has gotten misdirected. So later today, those who attended will receive an email with a link to fill out the online evaluation for today's workshop. And there'll be time at the end to complete the evaluation as well. You can print out your certificate later whenever it's convenient for you. And today's speakers have no conflicts of interest to report regarding today's presentations. And if he is ready, I would now like to introduce Joshua Marshall, Chair of the Watch Coalition. He would like to talk to you about the value we place on collaboration. Thank you.
Thank you, Dr. Smith, and good morning, and thank you all for being here. I would like to share with you about why we do what we do. In 2011, the Watch Coalition was formed by a group of dedicated organizations and individuals who are committed to improving the total wellness of children and families in Denton County. Our vision is, because every child deserves hope, the Denton County community dedicates its unified resources to equip our children to reach their full potential, mentally, physically, and socially, to achieve their maximum personal success. One key strategy to achieve this goal is by maintaining a diverse and active membership. We are a collaboration of both public and private organizations and individuals who are invested in the total wellness of Denton County's children. Our shared passion of improving children's mental health is the guidepost by which we base our choices. We understand the value of working together to improve children's mental health, and we're truly grateful for all of our members, volunteers, partners, and allies. We regularly work to strengthen the network of mental health professionals by offering educational and networking opportunities related to children's mental health, like this workshop. We also invite the parents in our community who feel they might benefit to attend these workshops as well. If you're a parent attending today's workshop, thank you so much for coming, and please feel free to visit the C4CH website, where you will find resources, information about community events, materials from past workshops, and much more. I would like to thank the members of the Education Work Group for their work in planning this workshop. I can see by all who came today that this is a much needed topic for us to discuss.
And I'm going to introduce our next speaker, Michelle Schoolwohlert, hopefully I pronounced that correctly, is an LPC EMDR trained and LCDC intern. She is the owner and CEO of Roots Adolescent Renewal Ranch, a dual diagnosis residential treatment center for adolescent girls in Argyle, Texas. Her personal and professional experience have centered on supporting adolescents and their families during crises involving mental health and substance use. Her focus is on addressing childhood trauma and getting to the root of the primary issue so that children can start to cleanse and retrain their brain for a renewed life of recovery and health. Thank you for joining us today, Michelle.
Thank you. I am going to share my screen, so we're just going to pray that I'm a little technology stunted, so here we go. All right. Can you guys see my screen?
Yes, I can.
Okay, perfect. All right. Well, thank you all so much. I am going to give you just so much information in the next 40 minutes, but I'm going to cruise through quite a bit of it, but I would love for you to have the information. So that's why I keep it on my slides. And then I know they're going to send out the presentations for you. So please feel free to use it, share it, whatever you need to do. I am not stingy. I think everybody needs to see this information. So I do want to say, before I kind of get into my presentation, I think it's important for you to understand a little bit of, I don't need to say my credentials. I don't need to say my education. I really want you to hear that our formula that we've created for our residential treatment facility for adolescents came from really 20 years of experience in dealing with a family member, my brother, that was an addict, and he went to probably 10 different treatment facilities. And Mr. Sparks, I imagine that you dealt with him many times over the years in Denton County, but he definitely went through the buying, the selling, so many overdoses, had to bring him back and resuscitate him several times. He did eventually pass away at the age of 33. He was sober for 2 years and he relapsed on cocaine. And the coroner, basically disclosed in the toxicology report that he did not take enough cocaine to have killed him, but it did have fentanyl in it. And so that is what eventually, caused his passing. However, I was able to, several weeks before his passing, he and I talked about how to do some sort of program for our community for the youth and preventing drug use, preventing these things from happening. With his experience, my industry knowledge, he had been to probably 10 different treatment programs. And what I want to get to is that all of those treatment programs, they really just focused on sobriety. They focused on putting a Band-Aid on it and, okay, the big book and what are the things you need to do to stay in recovery. And that's fine. But I think especially for adolescents, we have such an incredible opportunity to help them do a U-turn or catch them before they physiologically get into their addictions. And the way that we do that is really focusing on why they're using, why they feel like they have to self-harm, why they feel like they have to seek these comfort tools, to kind of mask their pain, which is what leads to addiction. So I'm so thankful that they've asked me to be a part of this piece of it, because this is really what we do. We really look into the why. We get to the root of the situation, which is why we call it Roots. And really that came from my brother 3 weeks before he passed. And serendipitously, we had this conversation. He talked to me a lot about what were some things that worked in his treatment programs, which didn't. And I'm telling you, he went to 30-day programs, to alternative schools, to 13-month programs, to federal prison, you name it, he was in it. And so when we created our program, we really, really looked at his firsthand experience. And really the key piece was getting to the root of it. He never found a place that would really clean out the wound, so that could properly heal. And then they also never looked at family systems. And so that's a big piece of what we do. So I just wanted to give you that little bit of background so that you could understand where what I'm about to tell you comes from. And again, please feel free to raise your hand, or if we can wait till the end, I'm happy to answer questions, but feel free to put your questions in as we go. Okay, so I'm going to get started. All right, so what is their why? So why are these kids using? So of course, one of the things is co-occurring disorders. We're seeing so much trauma, mental, like depression, PTSD, major depressive disorder, we're seeing, and I'll talk about that in a second, but we're seeing a lot of co-occurring disorders with this. Most 99.999% of the kids have unaddressed childhood trauma. Actually, I would say 100% unaddressed childhood trauma. There's definitely some genetic predisposition and environmental factors. I'm going to talk to you about the mind and body unwellness that these kids have right now, and then also about the road to addiction, which is that's what I'll end with and pass it on to the next presenter, who's going to talk about treatment and interventions. Okay. All right. So what are you guys seeing? And when I say you, I mean mental health professionals, counselors at school, teachers, parents, community leaders, coaches, all of that. What are you seeing? So I imagine that you're seeing a lot of absences, lack of focus, irritability, mood swings, dishonesty. I'm sure that you've met one child at some point that has told a little white lie. Zoning out or dissociation, avoidance is a big one. My favorite coping skill, although I'm adult and I'm getting better at it. Isolation, withdrawal, toxic relationships, lack of interest, risky sexual behaviors, distraction. I'm going to move this little guy here. Okay. Distraction with phones, excessive sleepiness, or not being able to sleep, poor time management, disorganization, changes in appearance, perfectionism is a big one, stress sensitivity, violence or aggression. Where did my sweet little girl go? She's completely changed. Hear that all the time. Change in activity, change in eating habits, and decrease in grades. And I could probably name 100 more. Oops, I gotta go back here. Okay. All right. So what are we seeing? So by the time they get to us, by the way, we are a residential dual diagnosis. So we see girls 13 to 17 years old that most of them have had several treatment episodes, meaning they've been to inpatient facilities, they've been to crisis stabilization hospitals, they've been to outpatient, inpatient, some residential facilities. But by the time they get to us, this is like the parents are like, I don't know what else to do. You are our last hope. We are at our wits' end. We have no idea what to do. So that's what they come to us as. And so a lot of what we see, sexual trauma, I would say 95% of our girls, which we've had 100 we've had 100 admissions in the last 2 years. So just keep that number in mind. So of those, probably about 95% of them have had sexual trauma, many times by a male family member, unfortunately. We've had a lot of parental abandonment, abuse or neglect by a parent with mental health issues, drug use with parents, death of a parent or a friend, many overdoses. Several of them have they've been in a coma, like Mr. Sparks was talking about, what it does. It affects your respiratory system. It affects so many things. And so the girls that have survived the fentanyl overdoses, which they're taking a lot of Percocets, which have fentanyl in them. So that's a lot of what we see. And if they do survive, they are either in a coma for some time or have some lasting health issues. So we do see quite a bit of that. Divorce and adjustment in parents, and I'll talk a little bit more about family systems in a second. Multiple suicide attempts, sometimes with just over-the-counter medication, sometimes with drugs, sometimes with cutting, sometimes with hanging. We're seeing a lot of bullying, drug use with partner, miscarriages, abortions. We have had a couple girls that have been pregnant. We've had girls with incarcerated parents, and then, of course, a lot of issues with their father figure. Some issues with mothers too, with enmeshment, but a lot with father figures. Self-harm, sex trafficking. We have had many girls that have been sex trafficked. We work a lot with police on that, CPS, of course. We reach out to the nonprofits in the area that can help the girls with that as well. We partner with them. Deal a lot with online relationships, violence and aggression, legal issues, CPS involvement. I was a crisis counselor at a school district before this, and I thought I wrote a lot of CPS reports there. It is nothing compared to here. So I don't mean to brag, but all of you school counselors, please enter my world, and I have plenty for you. And then we see a lot of diagnoses with, like I said, major depressive, PTSD, bipolar disorder. I really don't agree with this. I think you could talk to any psychiatrist and they would not either. Bipolar disorder and personality disorders are being, I think, overdiagnosed and too prematurely diagnosed, because what I'll talk about in a second is that trauma response has a lot of symptoms that mimic bipolar personality disorders. So what we're seeing is that if we can treat the trauma, purge that, process through it, and give them the skills, that a lot of the symptoms are reduced. And they would not be diagnosed with bipolar or personality disorders or even ADHD at the end of it. So it's been pretty eye-opening for us. Of course, general anxiety disorder, a lot of attachment issues. We've had a lot of girls that have been adopted either at birth or later in life. So they have some reactive attachment disorder. And then, of course, a lot of ODD, but again, those are symptoms that mimic trauma response. And so we try to get past the behaviors the first few weeks, and then we can really work on the why. Why are they having those behaviors? Okay, so I'm going to talk to you a little bit about trauma. Actually, that's the bulk of what we do, is work on the trauma. So I do want to talk to you about that. The SAMHSA definition, I don't need to read these words to you, but really they talk about not even the event or series of events, but the lasting effects that trauma has on the individual's functioning. and the physical, social, emotional, or spiritual well-being. We also use Pia Melody. I'm not sure if you've heard of her, if you look up the Meadows, but I love Pia Melody. She really focuses on codependence, and a lot of what she has taught and developed, we use in our program. But we really look at trauma as anything that was less than nurturing in childhood. And if we look at it that way, then it really changes the climate of how these girls are validated, I guess. Because trauma is not just words in a book. Trauma is, how does it sit on each individual's brain? What was it? And there are so many factors that determine that, which I'll talk about. But really, we talk about trauma as, something to one person, a certain traumatic event to one person can sit completely differently on another person's brain and in their body and in their mind and their spirit and all of that. And so we really look at anything that was less than nurturing in childhood. And I'll clarify that in a second. So, but it comes in the form of enmeshment, neglect, abandonment, abuse, all of those things. I am not going to play this TED Talk, but I'm leaving it on the slide because if you have not seen Dr. Nadine Burke-Harris's TED Talk on the impact of childhood adversity and the ACEs study, it's about 16 minutes. There is a section in there between minutes 4 and 10 that I usually show people, especially parents, because she really has a very concise way of describing the physiological effect on trauma and how it affects the adolescent's neurodevelopment system and how it lands on the brain. And it talks about, the fight, flight, or freeze. And the important thing to remember is that so it affects your reward system, of course, but also it affects your neurological system in the sense of, if you have a bear, and I'll talk about this in a second, but she talks about, like, if you're in the woods and you see a bear, okay, your body immediately tells you, you start having some physical effects, and immediately tells you, okay, do I go towards the bear? Do I run from the bear? Do I stand frozen in front of the bear? Okay. So you're going to have that, like, you have to have that fear so that you can make that decision. But what if that bear comes home to you every single night? Like, what if that bear is an abusive father? What if that bear is a mom and dad that fight constantly, and you look and you see domestic violence every night? Then you're always going to be heightened. You're always going to be in that hypervigilant fight, flight, or fear state. And that is what affects your functionality. So I would just really encourage you to go on here and watch this. I'm going to leave this. I'm sure you guys have seen it, but if you have not, I'm going to leave this link on here so you can go watch it, because it really is great, and use it as a tool. I show parents, and when I show this to parents, they're like, oh, okay. So they're not choosing, they're not choosing to behave this way. Their brains are affected by it. The ACEs study, I'm sure some of you have seen the ACEs study, taken it. These are the 10 major factors in the ACE study. These are the 10 major adverse childhood experience categories that she discusses. I think some people would agree that this is pretty antiquated. So many more things can be considered trauma these days, because it's all about that event or series of events and how it affects the adolescent brain. Okay. And how, depending on their support system, depending on if they're still exposed to that trauma moving forward, or if it was just a one-time thing, have they gotten counseling for it? All these other factors determine how the trauma sits in their brain and how it affects their functionality. So I would say, yes, we always give the ACE study, but we also provide about 50 other things that can be traumatic to them. But I will go back and say that the ACE study, the official ACE study that clinicians generally use, that we also use when they come in, these are the 10 major categories that are questioned. We do talk to them about little t versus big T. Again, anything less than nurturing can be considered trauma, but the big T's are generally things that people would not dispute. Okay. If you're in a natural disaster, if you have had physical or sexual or emotional or mental abuse, if you were in a serious accident, death or loss of a loved one, domestic violence, abuse, certainly major illness, witnessing death is a big one. And then you have like little t's. So interpersonal conflict, infidelity, divorce, legal trouble, relocation, shame, parent with a psychological or mental diagnosis. There's I think I would just say that again, if you might have somebody that has experienced divorce. Okay. So their parents divorced, but their parents were really good co-parents. They loved them. They did things together. It was very healthy. So that might really not be traumatic. But then you also might have a child that their parents have divorced and has been very ugly. There's been parent alienation and the parents don't talk and the kids have been put in the middle. That could be a really big trauma for them. So that's why it's really hard to just put a line down the middle of this paper and say what's big T and little t, but because again, it is so individualized and each adolescent is going to be affected differently. So I just want to run through this real quick. This is basically trauma on the developing brain affects 6 major categories. So it affects their ability to attach. So if you ask all of our girls that we say, does anyone have trouble forming and maintaining close bonds? Do you have trouble trusting people? Yes, all of them raise their hand and actually don't put it down for a while. So it does affect relationships, connection. It also affects their biology. So their arousal system is pretty dysregulated, sensory motor coordination. Their arousal system, it's like sometimes so we might tell them, I'm sorry, you're not going to be able to, you need to go back into group because you can't just come sit out here because you don't like what we're talking about. You would have thought that we took their cell phone, which I know you all know is just, a major trauma in their life, but you would have thought we took their cell phone. Okay. I mean, they have complete meltdown. So I'm sure that a lot of you experience that. I tell parents that all the time. Has anyone ever tried to take their child's cell phone? And I mean, parents are like, oh yes, police were involved. It was a nightmare. So anyway, their arousal system is a little dysregulated. So their reactions are not congruent with really what the issue is, the underlying issue is. Their affect regulation, they have a hard time experiencing emotion. So we tell them it's hard. Yeah, that emotion sucks. It sucks to be sad. It sucks to be mad. It sucks. These hard things are happening, but you have to sit in it. You have to sit in it because you have to figure out how to get through it and on the other side of it in a healthy way. That is really the crux of all of this. They've got to learn how to cope and regulate their emotions. And that just takes time. That just takes development of the brain. And I'll talk about that in a minute too. So behavior control, too much or not enough inhibition. Of course, a lot of teachers and parents and like they see the behaviors, but they don't understand that these kids don't have the ability to have impulse control right now. It's just that part of the brain is not working. So cognition, academic, social, emotional performance, of course, trauma affects that. And then also, of course, their self-concept. All of our girls have a lot of shame and a lot of guilt. And it's really for things that they don't have a ton of control over. And so we spend a lot of time really diffusing their shame, diffusing their guilt, building them up, empowering them, having them process through and understand knowledge is power. I tell them that all the time. And so we do a lot of educating on that and really working with them on their self-concept. This is a quick MRI. I love this slide. Parents, I love showing this to parents because on your left, you're going to see a healthy brain. On your right, it says an abused brain, but you can replace it with traumatized brain. Even like like a neuroatypical brain. So this could be somebody with ADHD even. But what you're going to see on your left is that there's a lot of red, right? There's a lot of activity. That means their neurons are building, their neurotransmitters are firing, they're connecting. There's just a lot of good activity going on there in their frontal lobes. That's where they're, the cognitive part of your brain. Okay. If you look on the right brain, it's a lot of just dark space, not a lot of activity going on. That's because that part of your brain, that part of their brain is the one that controls their, their affect regulation, their, really their cognitive, their impulse control, their decision making, their rationalization, all of that. So that's really not functioning. And so when parents ask their kids, why did you do that? And they say, I don't know. They don't know. They really don't know. But then what happens is because that answer is not good enough, then they make up an answer. Then that's when they start the lying and the dishonesty. And so that whole cycle and pattern, that's why I try to let parents know, like, don't ask them why, because you're not going to get the answer you want. So what we need to really work on is building the neurons. We need to keep encouraging that neuron production and that cell production and the neurotransmitters being wired properly. That's what we need to focus on. So, okay. So how does the body respond to that? The body responds to that with nightmares, flashbacks, hopelessness, insomnia, numbing, loss of interest, irritability, depression, dissociation, hypervigilance, self-harm behaviors, substance use, eating disorders, chronic pain, emotionally overwhelmed, panic attacks, all of these things. Okay, this is how their body responds. This is not something that kids are like, I'm going to wake up today and I think that I am going to deal with my pain by having a panic attack. That's what I'm going to choose. Okay, they do not cognitively choose that. That is how their body responds. So when you see these things, these are trauma responses. But what also does this look like? This might also look like bipolar disorder. This might also look like depression. This might also look like personality and mood disorders. But that's what trauma responses are. That's what they do. That's what they mimic. So I just like to educate people on that. This is the polyvagal ladder. Some of you may know this, some of you may not. I would encourage you to look at it. But this is basically their arousal scale. Okay. So we want the kids to be in this green section here. We want them to have good social engagement, be in the present, mindful, grounded, have joy. Okay. So this is where we want them to be. But the more aroused they get, meaning they're, all of those responses, the trauma responses, they go into fight, flight, or freeze. Well, that is where they're dysregulated. So we don't want them in that. We want to try to get them down to the green part. But we're going to talk about in a second. But then also, I think they're going to talk this afternoon about treatment and intervention. So I'll let them talk more about that. But I just wanted to show you this because we want to keep them in that green section. Okay. But most of the girls that come to us and adolescents in general, they're going to be in that fight, flight, or freeze pretty often, consistently. Okay. All right. So to get into that green section, this is what they do. Oops, sorry, too fast. Quick draw. Okay. This is what they do. They use substances, they, self-harm, risky sexual behavior, disordered eating, online dating, pornography, gambling, technology overuse, running away, avoidance. These are all of their comfort-seeking tools. This is what they can control because they can't control their brain right now. They can't control that part of their brain that is not developed, but they can control all of these things. Eventually they can't, they get out of control with them. But in their mind, these are the things that they can do to control their pain and find comfort. Okay, so our philosophy, our approach is that addiction is a secondary problem that comes out of a primary problem. So when we put all the emphasis on the secondary problem, sobriety, or not cutting or whatever the case may be, when we put the emphasis on that, but don't pay attention to the primary one, then how can we possibly succeed? Additionally, no matter what the addiction, it is an attempt to reduce emotional pain. So the question I keep repeating is not why the addiction, but why the pain. And this is spoken by Dr. Gabor Mate, who I adore. I would encourage you to study some of his work on trauma. But this is really our approach. Not why are you, not what is the addiction, but why are you using? Okay, so there are a few things that we have to understand, some factors as to why they're using to kind of get to, okay, now what's the treatment? What's the intervention? So one thing that's really important is genetic predisposition. So we have to understand the family history. And I tell people all the time, you can't deal with what you don't know. All right, so knowledge is power again. But a study of troubled adolescents says higher risk-taking behaviors are caused by not knowing stories of family history. Lower risk-taking behaviors are knowing themes of resilience or themes of vulnerability. So knowing your family history, even if you have a long line of addiction and mental health issues, even if that is in your family, it still creates lower risk-taking behaviors if you know it. Because if you know it, then you can deal with it. You can be prepared for it. You can say, okay, we have 3 lines of alcohol, like we have 3 generations of alcoholics in our family. So you know that you already have a propensity. So you know that you have got to stay away from alcohol. And if you do use alcohol, that you really have to be prepared for moderation or having a problem, or make sure you get a support system around you, prepare for it. So we do genograms with our families when they come in, and it really, really is eye-opening. So I would encourage you to look up some information about genograms if you don't already. One of my favorite therapeutic tools. This is just an example of a genogram. We have them generally go up 3 generations, and we look at, what was their relationships like? Did we have harmony and conflict? Was there abuse? What were some health issues, mental illness, behavior problems, legal problems, substance use, all of that. And genetics, let me move this up here. Okay. Genetics serve as 39 to 75% of the risk to forming an addiction or mental illness. So that basically creates that percentage of vulnerability to forming an addiction or a mental health issue. So genetics are definitely, there is a predisposition with genetics. Now, does that mean that every person that has a genetic predisposition to alcohol or drugs are going to become addicts or alcoholics? Definitely not. But it's certainly something that some DNA studies, you can have some DNA testing done. It's all about the genomes and what they're bringing from. I'm not a scientist or a doctor, but I can tell you that if you do get some DNA testing done, it can show whether you have the genomes that are going to produce more risk factors for addiction. So, all right. So I'm going to get into environmental factors. Definitely family stressors are factors for kids and their potential risk at becoming addicts or having mental health issues. I do want to differentiate. There's positive stress, there's tolerable stress, and there's toxic stress. So positive stress is actually good. Positive stress is maybe when kids have to go to the doctor to get shots. Okay, that is super stressful. That's still stressful for me, and I'm 47, but little kids, it is extremely stressful. But what happens? They go to the doctor, they cry, they're scared, they get the shot, mom's there to comfort them. They, a couple minutes later, they get a cute little Band-Aid and a sucker, and we're okay. And so they've gotten through that stress and they're on the other side of it. So the next time they go get a shot, it might not be quite as traumatic for them because they've already survived it, right? Okay. So positive stress is good. being anxious for a band concert, and then you perform and it's awesome and you get rave reviews on the other side of it. That's positive stress. Tolerable stress is maybe, like I said earlier, maybe a healthy divorce by your parents, maybe the death of a pet where you've had to experience grief. So these are the ones where you kind of like life lessons. They're hard, but if you have a good support system, you can get through it. Toxic stress, this is what causes generally the risk-taking behaviors, the comfort-seeking tools. It's the chronic stress. This is where it's prolonged. And I will tell you, by the way, the next bullet is chronic stress and trauma. Chronic stress. So research is showing that prolonged exposure to chronic stress or prolonged exposure to little t trauma or constant trauma or stress can be as detrimental or more to the development of an adolescent's brain than experiencing one bigger traumatic event. So it is really important that we do not discount, the bullying or the, I had one family, I'll tell you one time they called and of course you hear all the time, I don't know why my daughter is so stressed out. We give her everything she needs. Do you hear that? I'm sure you do. I don't have I can't see you all, but I'm sure you're all raising your hand. Yeah, I don't know why my kids are so anxious. I mean, they have everything they need. I don't know why. We've been married since she was born. I don't understand. I mean, we fight every once in a while. Well, I hear that all the time. So, one family, I was doing the pre-admission assessment and I said, well, and there's always trauma. So of course I always talk about can you pinpoint what the trauma might've been? No, I can't think of anything. She's got a brother and a sister. We go to church. We're, a very close family. She's got friends. We have good jobs. We give them everything they need. Well, long story short, fast forward, I find out that he had to move a lot for his job. So they had moved 7 times in 14 years. 7 times, not just from one school district to another. It was like Texas to Australia to California to Florida to Canada. I mean, they had moved everywhere. Well, there's a thing called displacement trauma. So think of all the adjusting this poor girl had to do. And then every time she would go somewhere, she might make some friends, which goes back to the attachment and being able to trust and connect. She might make some friends, but then she has to move and loses them. Well, eventually it's just hard to start fitting in, and then you get bullied, and then you start using substances. And then she also had a sexual orientation issue and was afraid to come out to her parents because they were very religious and not supportive of that. And so, okay, you think this girl is perfectly fine, or the parents do, but look at all that trauma that she had, right? Not to mention all of the issues that she got into once she started using and harming. So I just wanted to make that point about chronic stress, is that even if it seems like they don't have any traumatic events, and I put that in big quotes and bold and, italics, it is very, very common that there are a lot of things going on that the parents don't even see. Okay, moving on. Parenting styles. Of course, you all know the 4 parenting styles. Peer influences, use of technology. I'll get on my soapbox in a second on that. Lack of healthy support system, lack of structure, excess idle time, exposure to substances, lack of community, and lack of spiritual connection are just some of the environmental factors. Not sure how much time I have left, but I'm going to move through these really quickly. Okay, so then we have mind and body unwellness. So this is another big factor of our kids these days. And I will tell you that research is also showing that adolescents' brains are developing about 2 years behind their chronological age. So think of a 16-year-old. Okay, their brain's probably at about a 14-year-old level. Well, think of a 13-year-old. We get some 13-year-olds, unfortunately. Their brain's at about an 11-year-old level. So we really have to work on meeting them where they're at and adapting their treatment programs to their developmental age. And what it's showing is that these are some of the things that are affecting their brain development. So sleep habits, Kids right now have the terrible sleep habits. Some come into us, they don't go to sleep till 4 in the morning and sleep till 4 in the afternoon. Nutrition, they're not eating throughout the day. They might have a big giant, McDonald's meal at 10 o'clock at night, and that's their meal for the day. They're not really getting a lot of physical activity. They're spending a lot of time on technology. I think we're probably a lot of us on the same page about the negative effects of technology. I want to take 2 minutes of time and really talk to you about what technology physiologically. I've done a lot of research. I can give you the resources or the sources, but I want to tell you a couple things that technology is really doing to our kids' brains, and the effects it's having on them physiologically. One is that the screens, not necessarily TVs, but like the iPads and the iPhones, the screens, that blue light, it actually inhibits your natural melatonin production. So what that's doing is that's not allowing them to go to sleep the way that they need to go to sleep and get the sound sleep they need. Okay. So it really truly is affecting their sleep habits, not just because they stay up on it, but because when they're on it, when doctors say don't get on technology 1 or 2 hours before bedtime, there's a reason for that. It really does inhibit their melatonin production. The other thing it is doing is that they're not able to practice. They're not able to practice communication, effective communication, and interpersonal skills because they're on a screen. So they're not getting that face-to-face communication. They're not learning how to filter what they're saying because they have to deal with the reaction of the person in front of them. They're not able to use assertive communication. They're not able to feel that anxiety and talk through it anyway and get that response. Also, you need that personal communication to produce dopamine. Kids need that. So they're not able to practice that. So when you see kids that are not like socially mature, it's because they haven't had the practice that we used to have. They have a lowered recognition of external cues and external stimuli. And so they're not really, how many times do you call your child from the other room or from standing right in front of them and say, hey, I have a question for you, or hey, did you do this? Or do you want this for dinner? And they don't even recognize it. They don't even recognize you're talking to them. The other thing is they're having trouble having a good understanding of time management. How many of your kids are like, we say we're leaving in 5 minutes. They'll be like, I'll be ready. Okay, what are you doing? Are you putting on your shoes? No, I'm about to get in the shower. Okay, that does not make sense. That doesn't just take 5 minutes. And then your mother gets her blood pressure skyrocketing. And then I'm mad when he gets in the car. So like, they're just not understanding time. The other thing is that they are overstimulated. Their brain is overstimulated. It's not stopping because there are so many different things. They're doing social media. They're looking up Google. They're looking up, YouTube videos. They're looking up TikTok. They're sending messages. They're sending Snapchats. They're also trying to listen to a teacher, give them instructions. There's just so much going on. Their brains are not getting a break. The other thing that I think is the main thing is that it's teaching them the need for immediate gratification. So our kids do not have patience. They do not know how to be bored. They do not know how to be self-sufficient, because if they get 1 minute of like, oh my God, I'm not doing something, I have to be doing something, that's where they reach for their phone or technology for their dopamine, right? And that's why they can't sit in the hard, because they have to have immediate fix. So instead of them being able to say, oh, that doesn't feel good, I just had an argument with my friend, I'm just going to sit in this, they don't do that. They have to go harm, or they have to go take a substance, or they have to go run away, because they can't just sit in that feeling of this doesn't feel good. So there are so many things that technology is affecting these days. And so I'll step down for a second off my soapbox, but man, I really, really would encourage, it's going to just really take the parents, I think, being agents of change with that. I appreciate what the teachers are now doing, the schools are now doing, but I really think it's going to be parents that are going to have to stand strong on that. So, okay, moving on. Medication management, it's really important that if they are on medications, which I do think many of them are over medicated, but if they are on medication, they need to management or come off of it in a supervised way under a physician. Meditation, mindfulness, they really need to work on being mindful, being grounded, being in the moment, giving their brain a break. Spiritual connection, we see a lot of girls that come in that have been spiritually harmed and have a lot of resentment, and they don't really have any kind of spiritual connection or foundation right now. So we really try to help them find that, whether if it's not in God, it can be in, the universe, it can be in their self, like their authenticity, it can be with nature, it can be with the sense of love and relationship, but we do try to help them find some sort of spiritual connection. Also, their self-esteem and self-concept is just tanked right now, and so we do a lot to try to build that back up. And then they really have a hard time seeing a sense of future. They're having a hard time seeing 2 steps in front of them. And so we really try to give them the skills that they need to see a future, see beyond what this moment is. And they have to cleanse to be able to, they really have to cleanse the trauma and everything that's just fragmented and built up in their brains right now to be able to see that. Let me see, I'm almost done. Okay, so the road to addiction. So experimentation is really just trying something 1, 2, 3 times. Misuse is really inconsistent use with or without experiencing consequences. Abuse would be consistent use in a risky behavior and continuing to use despite experiencing negative consequences. I would say that this is the majority of the girls that we see, is that they have abuse. Okay, they're not probably to the point of addiction yet, which is the beauty of dealing with adolescents, because their brains are so elastic and they're developing at such a fast pace that we do have the ability to retrain it, which is great. So we've only probably had 5 to 10 girls that have truly probably been dependent to where once they go through our program, they don't go back, that they still continue going back to it. Maybe there's about 5 or 10 that relapse and need further care. But what we find is it's really abuse because they're trying to fix their pain. They're trying to mask their pain. But once we can get the pain processed and purged, then they don't have the need to use anymore. So moving on then to dependence, this is really where I guess you would be called an addict, which I hate to say that, but addiction and dependence are really structural changes in the brain that have created cravings, withdrawal symptoms, loss of control, inability to stop, using more than intended, blah, 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 all those things. So that's really dependence. And that's harder. That's harder to recover from. And that's the one you kind of have to deal with on a lifelong basis, unless we can catch it. And really catching it before their brain is fully developed, that's what we have to do. Okay, so how do these become addictions? So these are your brain development phases. So you have neuron production. Your brain produces about 200 billion cells by the age of 12. Most of them actually come between the ages of 0 and 6. So when we say those are really the formative years, they are. Like, it's really important that kids from 0 to 6 have a really good, stable support system and healthy environment. But 90% of their 200 billion cells will be produced by the age of 12. So if any of you start seeing these changes, you're like, what has happened? Like, this was the sweetest little girl, and now she's like 12 or 13, and it's like she's been abducted by aliens and is using drugs and running away and self-harming and having sex and all this stuff. What happened? Well, adolescence and puberty, that's when they start reorganizing. They're starting okay, I have all of these billions of cells. Now, what do I do with them? Okay, well, that starts around adolescence, where they begin reorganization. By the time they're 25, which is, you've all heard, around 25 is when your brain is fully developed. I would argue it's maybe a little bit later now because of just, processed foods, chemicals in foods, lack of activity, technology, all the things we talked about. Then you're basically pruning all of your brain cells that you don't need anymore. Okay, well, if you have somebody that's had trauma, you have somebody that their parents have been lawnmower parents or helicopter parents where they have really just made all their decisions for them. They haven't let them fail. They haven't let them learn autonomy. They haven't let them learn independence. They haven't let them fall. That's then what the adolescents, like, they lose the brain cells of being able to be self-sufficient and independent and autonomous and be healthy. And so basically by the time they're 25, about 50% of their brain cells are remaining. So the whole use it or lose it principle, that's very applicable here. And so it's really important that between the ages of 0 and 12, when those cells are being produced, that we're really basically you're a director. Like, as a parent, you're a director their first 12 years of their life. At 12, you kind of become more of like a teacher, coach, trainer. And I can give some really good resources for that, but that's really a roadmap. So that's why you see a lot of changes in adolescents and kids kind of taking that fork in the road around age 12 or 13. It's because they're starting to reorganize their cells. Okay, so how do they reorganize their cells? It's really based on survival mode and pleasure mode. So you have the limbic system, which is like the survival mode, fight, flight, or freeze. That's really like the brain's accelerator. So that's why kids are like, it's so strong. Like, your limbic system, your amygdala, your emotion central of your brain is just so much stronger as you're developing than your cognitive part, your frontal lobe. And so that limbic system is determining whether you are in fight, flight, or freeze mode, or if you're in pleasure mode, which is calm and happy. All right. Well, how is that determined? Well, it's all about your dopamine. It's all about the dopamine production, your reward system. And so this is where I want to talk a little bit, and I'm almost finished with my presentation, but this is a really, really important piece. So this is what happens when you begin using drugs, you begin self-harming, you begin with sexual behaviors, you begin with toxic relationships, technology, any of that. Okay. This is what happens. So you basically have a pleasure threshold. So everyone produces, well, let me go to the next slide. Okay. I apologize for this graphic. I kind of added it last second, but I can give you the resource for it. But this is a really good graph of dopamine. So if you look at where the arrows are pointing underneath that dotted line, and you'll see kind of that blue squiggly line, that's really where your normal dopamine production and changes are going to be. So that red line, that's your normal, I'm sorry, the black line is where you're like your normal dopamine threshold. Okay. So generally your body will produce dopamine up to that line. The blue squiggly line is just kind of like, okay, you have a good meal, or, you have your first kiss, or you have a good time at a movie with a friend, your dopamine's going to be up a little bit. All right, let's say you have an argument with a friend. Let's say you're really hungry, whatever, your dopamine's going to dip a little bit. All right. Then it shows the different levels of, like food, sex, cocaine, meth. And, I could give you 100 other pleasure seeking things and what their levels are. But this is what happens. Okay. When you start using cocaine, meth, self-harming, sexual activity, gambling, pornography, what it does is it creates spikes in your dopamine. Okay. It's basically synthetic dopamine spikes. What happens when you do that and you cross this threshold, which you'll see is like the black line, when you cross that threshold of what your body's really not supposed to have more than that amount of dopamine, then your body's like, oh, wait, I already have enough dopamine. I don't need to produce my own. So your body naturally stops producing dopamine. So the only way you're getting dopamine at that point is to use the drugs or is to do the addictive behavior. Okay. So if you look at like the meth, when you take meth, that produces 1200% of the dopamine that your body thinks that you need to have. All right. So think about, let's just say girls that come to us and they have been on a meth binge for 2 weeks. Okay. They come to us and we take their technology, we take their toxic relationships and any communication, we take their drugs away from them, and their body is not producing any dopamine of its own. They have no dopamine in their system. They have no feel-good drug in their system. So what are they going to do? They're going to relapse. They're going to find a way. They're going to run. They're going to self-harm. They're going to restrict their eating. They're going to do anything they can to try to feel better because they have no dopamine in their system right now. So when our girls come to us, we basically try to replace these synthetic forms of dopamine with natural forms of producing dopamine, which can be personal communication. It can be feeling better about yourself. It can be having regular meals. It can be getting good sleep. It can be getting an A on a test that they haven't gotten an A on for 2 years because they haven't been going to school. It can be fishing and catching a big fish. It can be playing with the animals. It can be having a good conversation with their parents. It can be making a really cool painting. It can be like having a realization that, oh my gosh, I actually am worth something. All of these things, reading a book, doing a puzzle, watching a cool TV show, doing Just Dance on the Wii. Like girls love to do that. All of those things are natural dopamine producers. So when parents say, I took her phone away because I am not going to let her do that. Okay, that's great. But let me just tell you that is going to cause so many other problems because you're not replacing it. So parents that take technology away, I agree completely because I think it's harming them. And you have to replace it. You have to replace that dopamine producer. Okay, so this is just some statistics. The following percentage of users become dependent. So 10% of marijuana users become dependent or addicted, 21% of cocaine users, 23% of alcohol, and 68% of nicotine users, which I won't even get into the effects of that right now. So, all right, and I think this is my last slide. This is just kind of the long-term effects of dependence or addiction is cognitive deficits, attention deficits, poor impulse control, reduced working memory, learning deficits, inability to change behaviors, inability to learn from adverse consequences, over-reliance on automatic limbic system responses, inability to delay gratification, which I talked about with technology, apathy or complacency, and really impaired empathic response. Finding empathy when you're dependent on a substance is really difficult. But there is hope and wholeness in the adolescent brain, which I said, this is like my favorite. I always tell parents all of that. And the brain is so elastic. And so like changes in the brain can happen. Our formula that we have found that helps is really purging them. It takes time. When they get to us, it's not a 30-day fix. It's not even a 90-day fix, but 90 days does give them a really good start. And then we also work heavily with the families because they have to be agents of change as well. And so our formula is kind of like, get them in there, cleanse them, get away all their distractions. It takes a few weeks, believe me. There's a lot of drama with putting 14 to 16 adolescent girls in one house together. They're all on their periods at the same freaking time. So you're welcome for that, that we're dealing with that, not you. Also, there's a lot of drama. So we use that as a therapeutic opportunity to teach them some interpersonal skills, some, work like dealing with peers, conflict resolution, anger management, all of that stuff. But if they can really cleanse and purge that trauma, and then we equip them with coping skills and experiences and all of that, and then we empower them and let them know that they are worth it and they are enough and they're powerful and they have a future. Like this was their story. so far, but they get to write the rest of it, it really can produce some positive changes. So there is hope in the ability to retrain the brain. But I know that the next speaker is going to talk about, treatment and intervention. So I'm gonna let them do that. I would really encourage. I have so many resources, but I would really encourage you to one, read The Body Keeps the Score. Of course, that's kind of a standard with trauma. There is a workbook to it. Also, Pia Melody's Facing Codependence. That's a really good book that we use that talks about trauma from a childhood perspective. And then this whereabouts guide, I don't know if you've all heard of this, but it is such a good, I don't know if you can see my screen, but it's right here and it looks really big, but it's very, there's a lot of good illustrations, so many good statistics. There's a lot of good resources in it too. It gives you like a sample cell phone contract. It talks about any age group that you need and how to address them and what kind of executive functioning growth that they're having at that time and how you can facilitate that and encourage that. So I would recommend those books. And then I think that's it. I'm gonna kind of give it to, I guess, the moderator. Trying to find my screen here. Okay.
Thank you, Michelle. I appreciate that. So I was going to open it up for some questions. If anybody wants to put that into the chat, they're welcome to, or you guys can wave your hand and then we can certainly unmute you. There is a question in the question and answer box that says, as we know, technology has significantly impact on the brain and behavior of adolescents. What are some solutions that you would recommend?
Honestly, I will tell you that I know that causes the most conflict with families. When we get them, we don't even let them bring their phone and they don't get any technology and they don't even complain about it. It's the craziest thing. I thought we were going to have to detox them from that, but they don't even complain. For 3 months, they don't complain about not having a phone, not having social media, not having connection to the outside world. I really think it's a release. So I would encourage parents and teachers, like, I know their reaction is showing that they're very angry about it, but internally it's actually helping them so much by just removing that. And it doesn't mean that they can't ever have it. Maybe 1 or 2 hours a day or, after school, maybe everything but social media for a while. But I would just say you have to replace it. You have to replace it. And I need to provide like a whole list of things you can go do with your kids or encourage them to do or provide at home. But it is affecting them. And the only way to really do it is just replace that with other things would be kind of my main point. But I know that's hard. And this book, by the way, it has some really good scripts on how to talk to your kids about the need to reduce their technology use. It's just, this book is awesome. And I don't even have any ties to it. I just love it as a resource. So yeah, I have a list. We've created, after 2 years, I mean, the silliest things you wouldn't think would be a big deal. Like literally we have chickens. I know not everyone can have chickens, but these girls, like, they love to play with the animals. They love to go fishing. They love to go on just walks around the property. They do little scavenger hunts, having campfires, doing Just Dance on the Wii has been the funniest thing to watch because it's so old school, but they just love it. Yeah, I have a list of probably 100 things I can provide. Yeah.
Yeah, you definitely have some interested people that would love to see that list.
For sure.
Any other questions from anybody in the audience? Oops, I think there might be one in the Q&A. Let me look real quick. Okay. I'm not seeing any more questions. Thank you, Michelle, so much for taking the time to present that information to us. I really appreciate it. It was very helpful.
Actually, real quick, there's a couple things in
Oh,
the Q&A real fast. Someone said, I work with early childhood intervention, 0 to 3. We're learning recently about the concept of virtual autism or screen autism. We start early trying to eliminate or decrease screen time. Are you aware of this concept?
I am not. I would be fascinated to hear about that because I just think, and I'm old school. I read books. Like I want to like see the pages in front of me. But I think there's something to that. And I think, again, I'll get off my soapbox, but I would be fascinated to hear about that. And I think we're going to have to really, I know it's a huge cultural shift, but I think we're going to have to really work on the whole screen time thing in general with all ages to get a healthier society, but that's a whole different story. But I would really love to hear about that. I think that that's great. I support that completely. And I don't think it's just for autism. I think it would be for any human being, just for your brain development.
Mm-hmm. Yeah. And then Areli, I'm going to unmute you because she has asked to say something. So I'm going to try that.
Don't say anything mean. I don't like that.
No, hi, my name is Areli. I was actually going to say, like, I really like your presentation just because a lot of the times, as professionals, as teachers, as, just older adults, when we're dealing with youth, we kind of take things personally when it comes to our kids. And the fact that you're like, you know what, there's an underlying reason, and it comes to the biology of it at the end, right? Or the brain structure of, the trauma they've been experienced and their response, right? Like you mentioned, it's kind of like programmed and already, and that's their active state. And I feel like as parents and as adults, we tend to forget that. Like their response is not towards us, it's mostly because that's how they've been wired kind of all the time. And then we're trying to teach them new skills. And during the process, there's resistance and just being compassionate and being patient and really, getting to know them and teaching them those new skills. I just thought that was amazing. And because I don't know, I feel like adults sometimes we get this like ego of like, I know what's right for you, I know what's good for you. And like you said, like, oh, well, if you're gonna take away the phone, then give her something else. Give them something else, for that reward or um and like you said, the big deals for them are not for us, but in their mindset, to put ourselves in their situation, in their place. And it's not about like rightfully, but it's more about like, okay, I need to meet them at that place. And I just thought that was amazing.
Awesome. Thank you for saying that. And I hope you do feel validated because it's taken us a while to learn that, but honestly, they don't. And so many of the girls go through our program and at the end they're like, oh my gosh, who was I at that point? What was I doing? Like they don't even realize their behaviors. And so if you can keep that in mind, like they're so strong-willed and they learn all these words from technology and all that. But if you can remember that they're children, and they need us to guide them. And it is hard not to take it personally. And I get why parents get so frustrated with their behaviors, but I will tell you that we really encourage our girls to disclose their trauma to their parents because most of the parents don't know. And that we don't do it, but we encourage them to. And I will tell you that there is a complete shift in the parents. We see it every time because when they learn what their kids have been through, it shifts them from you're a problem, your behavior is outrageous, you're running away, you're doing drugs, you're a bad kid, to oh my gosh, I am so sorry that happened to you. Why didn't you tell us? We could have been there for you. And it is just such a complete shift. And so just knowledge is power. I just keep saying that, but it's really important. But thank you for saying that.
And there's another question that has about your staffing at your therapeutic program. Is it all female staff or is there multiple, is it a diverse staff, I guess?
Yeah, so that's a great question. All of our staff is very trained in mental health. We have about 35 staff members. We keep anywhere from 14 to 16 girls at a time. They stay an average of 90 days. It really is about an average of 90 days, some less, some more. We, of course, deal with insurance issues all the time, but we have about 35 staff members. We only have 3 male staff members, and that's not because we haven't tried. We have had, it takes a really, because these girls come in and they've many times been wounded by men. We have to be very, very careful that the men that are there, that they feel safe around, they can trust, they don't feel threatened. And so it does take a very strong vetting process for that. That's not because we discriminate. That's really because we want to keep them safe. So our superintendent and outdoor education person is a male. Our director of nursing is a male, and one of our chefs is a male. And we do have a pastor that comes in and does spiritual care and pure connection once a week, and he is a male. But other than that, everyone's a female. We've tried some male counselors, and the girls just it's just really hard for them to open up and feel comfortable and build that rapport. And so it just hasn't worked. And it's been a mutual, like, this isn't working. But does that answer your question?
Yeah, I think that probably answered their question that they had about your staffing.
Yeah, they're all very trained in everyone is very trained in mental health, SAMA training, crisis, nonverbal de-escalation, training out the yin yang. So.
And there's another question. Do you ever do workshop for families?
Yes, we are actually just about to open a new retreat center in Argyle that we're going to start doing, because we do a an intensive for the families in our programs that are about 3 days long. And they are so intensive. And the families talk about how much of a game changer they are, and they wish they could have done it before they even brought their girls. So we're actually about to open a retreat center where we're just going to do family retreats, where we'll have a few families at a time for 4 to 5 days, and that will be open to community families. So more on that to come. Thank you for asking.
Wonderful. Thank you. Okay, so I'm going to introduce our next speaker. Drew Dutton serves as president and CEO for Phoenix House in Texas, a statewide nonprofit specializing in adolescent substance use treatment and prevention services. Drew has worked in substance use and adolescent treatment since 2011, developing innovative multi-family group, aftercare, parent education, and residential treatment models. Nationally, Drew provides professional trainings, lectures, and consultations in the areas of addiction, positive psychology, and solution-focused counseling. Motivational interviewing and staff team development and cultural. Drew serves on various committees in the field of counseling and substance use throughout Texas. He is an adjunct professor at Texas Christian University, teaching addictions counseling for graduate students. Thanks you, Drew, for joining us today. We look forward to it.
Thank you. Likewise. All right, let me get this up.
Okay.
All right, so I'm going to be talking a little bit about treatment and interventions today, and I hope to provide maybe a non-traditional approach and really try to hone in on some things that are a little bit different from my background with substance use treatment and prevention, and a lot of the research I've done around what's been effective for individuals, with a big focus on adolescent population, but a lot of this is applicable to adults as well. But the bulk of my work and research has been done with youth. I think the best kind of metaphor that I use for talking about this is this diagram. And what this is Wald's World War II planes. In the U.S. during World War II needed to be able to win the war through the air if they were going to win World War II. So a lot of times wars come down to percentages: who had a little bit more ammo, a little bit more fuel, a little bit more soldiers, was there a little bit faster, whatever it might be. So they actually partnered with statisticians and mathematicians to be able to figure out how they could get a mathematical advantage during combat. And what they did is they hired Wald, who was a statistician who'd been forced out of Austria So he was very motivated to help fight against the Nazi Party at the time. They asked him where to armor their planes because if they put too much on, they're too heavy, they fly slow, they burn up fuel. But if they don't put enough armor on, the planes are too easy to shoot down. So where should we put the armor and how much of it? Well, Wald had them start mapping out. He said, when the planes come back, I want you to map out, do a whole scan of the plane, find any bullet holes, start mapping them all together and give me that map at the end of it after a few cycles. And they produced something like this. And the sergeants felt ridiculous for asking because they felt they knew exactly where to put the armor now by looking at this. But Wald said something that really shocked everyone. He said, you're going to put the armor where the bullet holes aren't. And that made no sense to anyone at first. But what Wald highlighted was that these were all the planes that had made it back, meaning he had a map of everywhere a plane could be shot and still fly safely. And his theory was that the places that we don't see bullet holes means if they get shot there, those planes go down. And Wald was correct. Those were the vulnerable spots of the plane. They ended up armoring them in the right spots. But their instinct was to make the problem infinitely worse. They thought that they had identified what the actual issue was. They thought that they had seen the way to go about addressing this. And the way that they would have done it would have not only been not helpful, but actively harmful, because it would have made a more slow plane that was easier to shoot down than the ones before. And I think we make that mistake a lot when it comes to substance use disorder treatment and addiction as a whole. We think we have an understanding of what's really going on, and we actually exacerbate the problem by the way that we look at it. So when we talk about how to armor the plane, if we carry this metaphor through, where are the bullet holes? Where's the place that we get drawn to? Well, a lot of times we wind up in isolated, very reactive interventions. There's a lack of prevention efforts. There's a lack of resources up front. A lot of times it's in response. We see a big push for harm reduction initiatives and Narcan and a lot of these things going through, but it took never before seen death tolls of US citizens before we started to make some of these measures. And a lot of times treatment is on the back end as opposed to the front end of things that we could do. We tend to approach things with punishment and consequences. By and large, the symptoms of addiction have been made illegal. And we try to treat and resolve these issues through the criminal justice system as opposed to a treatment system or a treatment model. And then lastly, a lot of times we use didactic lecture films and tapes, which in a comprehensive study of over 55 different treatment approaches you can use for alcohol and substance use disorders, didactic lectures was the absolute least effective measure examined as far as conveying information effectively to someone dealing with a substance use disorder. So where does the armor actually go? Where do we need to start putting these things? And what is the different approach that we can take to get us out of some of these outdated models? And we'll talk about some of the outcomes that we face as a result. Empathy. If you leave my presentation with anything, it needs to be a sense of empathy and understanding for what an adolescent and individual with addiction is going through. I think Michelle did a really good job covering what the brain is going through, meeting the adolescent brain where it's at. Utilizing strengths-based interventions, and then use of positive psychology principles, which we'll talk about as well. So access to care. How do we look? Well, we lead worldwide in overdose deaths by country, and unfortunately score very low, if not dead last by a lot of measures in our ability to provide access to care of those that are dealing with opioid use disorders. We're up to over 300 overdose deaths per day. It's the leading cause of death for all Americans under the age of 50. So before car accidents, cancer, gun violence, a lot of these different things combined, we see that that's the number one killer for individuals in the US, with fentanyl, obviously, as we talked about, being the leading driver of that. How does Texas rank within, well, Mental Health America did a study for 2022, and Texas was ranked dead last in their ability to provide access to effective care, 51st, because they included DC in the study. So it starts to paint a pretty alarming picture about the state of available treatment for individuals, especially youth, in the US and in Texas. So why do we see these gaps? Well, one, we tend to silo substance use disorders. Secondly, we tend to stigmatize and provide a lot of different, misinformation around harm reduction. Came in the wrong order and threw me off. Harm reduction is an area that we seem to have some misunderstandings that are getting broken around. So we see a lack of it kind of being rolled out. Substance use disorders are incredibly stigmatized compared to the other silos that we'll talk about. Substance use treatment is highly unaffordable. Most families cannot afford to access the care that they need or the care that their child needs. There's a lack of available providers, especially for youth that are unfunded or underfunded. And we utilize a lot of outdated practices in the care models that we implement. So what do I mean by siloing? So we've got healthcare, and there's a tremendous amount of empathy, supports. We've got ribbons, fundraisers, banners, everything, you name it, for medical conditions and people that are struggling with healthcare issues. And there's an overwhelming amount of research and support. In the separate silo, we've kind of carved out mental health to be separate from physical health. And we see and we continue to see progress with moving forward with being proactive and embracing and destigmatizing mental health. But that underlying stigma is still felt in the United States. There's still those undertones of someone who's crazy or what it means to need a therapist or to be on medication. And there's a little bit of that stigma there. Substance use disorders have been carved out completely separate from all of this in a whole nother means where it's just we've got these old kind of underlying and outdated and inappropriate terms of just thinking these are bad people or these are criminals or these are people that lack morals and values. And that's what the original model was for dealing with substance use disorders, was the moral model. And it was the belief that these were just immoral people that needed to be taught a correct way to live. But everything we know about the brain and addiction and everything we're seeing by no means supports that. But we still sense and feel undertones of that and have people that are fully kind of bought into is misinformation around these different models. So we've separated these out unnecessarily into different care models with different funding sources and different resources instead of integrating all together. When we talk about the different levels of care, we talk about siloing, we talk about harm reduction. We've got prevention, treatment, and harm reduction. You can think of those as kind of the three legs of this stool that's going against substance use disorders. So if you are driving a car, the speed limit signs and the road markers are a form of prevention. They're trying to prevent crashes from happening. Now, if you get in a crash, your airbag deploying is a form of harm reduction. Airbags by no means prevent car crashes, and harm reduction is not intended to prevent. It's intended to keep someone alive if the event occurs. So Narcan is intended to keep you alive. In the case of an opioid overdose, it is not intended to reduce the use. And the US has been very unwilling to embrace harm reduction with the misinformation that it will promote use. If people have these things available, that they would do it more, which is just as misinformed as thinking if you put airbags in cars, people will just want to go crash their cars. Or if you put fire extinguishers or sprinkler systems in a building, it's just going to encourage people to start setting buildings on fire. But we've had that thought and that misinformation around substance use disorders. And then lastly is treatment. So the ambulance that shows up and provides that medical care. So ideally, prevention would be so effective that we don't have crashes and don't need that, but that's just not the reality that we're in. We really need all three. We need prevention to try to minimize the impact. We need harm reduction so that when things happen, they're not fatal consequences. And then we need treatment for the individuals who are struggling with this and prevention was ineffective or inaccessible or whatever it might have been for their particular case. Stigma. Over half of individuals don't even seek treatment because of the stigma associated with it. And this includes mental health, and it's even higher for substance use. And it's really hard to get the data because so many people are unwilling to self-disclose if they're dealing with or a loved one is dealing with a substance use disorder because of the very stigma that's around it. A lot of the stigma that we have is in the language that we use. You know, if you have something in your system on any other type of drug test or drug analysis and it's there, you're labeled as positive. The common term throughout like probation and court systems is if a drug comes back positive in a system is that the lab was dirty. And you think about that, the words that we use and the labels that we put on individuals who are dealing with substance use disorders, when we say things like junkie or abuse or dirty, these things add up. And a lot of people don't recognize how much they might stigmatize things, even just driving around with their family, with kids in the car. When people make comments about, oh, look at this guy here over on the side of the road. I bet he's on drugs, or I bet he's doped up, or I bet he's this, or I bet he's that. Well, if that kid grows up with that information getting fed through, they start to create a picture and an image of what it means to deal with substance use. And it's a very negative picture and image that gets created. So if that individual and that kid starts to struggle, are they going to want to go to the parents that have created this label of what it means to deal with a substance use disorder and talk openly and honestly about what their struggles are and what they're going through? So it's really important to think about the language that we use when we use things like choice and things like that, where we take out the disease model and we're not being sensitive to what's really going on with someone dealing with these different types of issues. And then that moral model that I talked about is the biggest part, which still exists, unfortunately, today. And we'll talk about how it's incorporated into even our Texas administrative code to this day. Affordability. Recovery Centers of America did an annual study and found that single episodes of care were anywhere between $51,000 to $141,000. And that can include detox, residential, partial, and outpatient, all being separate episodes of care with their own costs. Most individuals cannot simply afford a privatized version of being able to access the treatment that they need, or parents. And we're talking about kids who have no ability to control or navigate the financial situation of the family that they're born into, or the insurance policy that their parents happen to have, or the Medicaid that they happen to renew or enroll in or not enroll in, but it may have significant consequences for whether or not they have the ability to access treatment. In Texas, while last in access to care is first in uninsured youth. So the amount of kids that don't have access to be able to get this treatment due to a lack of insurance creates a tremendous gap. So when we look at Texas and that accessibility, you can go to SAMHSA's treatment website, treatment locator. I think findtreatment.gov is the newest one. And you can put in, where are all the substance use providers? And this pops up and you think, great, this is phenomenal. But what if I'm a kid? And what if I don't have the ability to pay or private insurance? What do my options start to look like if I'm an adolescent in Texas? Well, you get down to less than 5 providers. There's very few providers left, and the ones with red circles are the ones that are available for girls. So this would be an individual who needs help with their substance use and honestly co-occurring mental health at the same time, because we need to stop siloing treatment episodes. They don't have the ability to pay or afford treatment, so they offer some type of payment assistance for the family, or they take government grants and funding. We get down to just a few remaining treatment centers that are left. Phoenix House, the organization that I'm a part of, has had to shift completely to prevention and out of treatment ourselves. And we represented about 40% of those remaining treatment centers that were there as a result of the lack of state funding available in Texas for these kids without insurance, all in the midst of this tremendous rise of substance use disorders that are disproportionately affecting kids, especially when it comes to overdose deaths. Bad practice. Bad practice is the one that we see absolutely everywhere, and the one of greatest concern, and what we're hopefully going to work to try to switch out today as we talk about that metaphor. So those practices, they tend to use that lecture-based introduction. They tend to be punitive and consequential and stress-inducing. And if we think about that, we talked about the fight or flight system in the presentation before. That is the biggest trigger for a relapse. When you don't have access to your prefrontal cortex and you get into that fight or flight system, someone who's in late stages of addiction, that's the part of the brain and the channel that is active when someone is in active substance use. So when you trigger or induce stress, you activate that part of the brain that is associated with continuing to use and seeking drugs. So when we put people in stressful environments, think of the Scared Straight program, where they would take kids into jails and try to terrify them. Brain-wise, that's the least effective intervention you can do, because you're just putting someone into fight or flight the entire time. They're not going to process the information. They're not going to retain it. They're just going to be worried about their safety and trying to look further way out. If they have a history of substance use disorders, it's going to promote cravings and return to use as a result. So it actually exacerbates the issue. Again, putting armor in the wrong spot. these practices aren't based on neuroscience like we talked about. That's a lot of what I present on is what goes on with addiction in the brain and the dopamine cycle and everything we kind of touched on before. One I'll talk about now just for sake of time and being to kind of able to tap into what we have is temporal discounting. It's kind of a unique one. So on this graph, you see these activity levels in bars. And what they did is they measured our prefrontal cortex response to rewards and consequences. So winning the lottery, getting hit by a car. Those are just the two first rewards and consequences that come to mind. And they had us think about ourselves and others and in the present and in the future. So this white line that we see here is what happens when we think about ourselves in the present. We see a tremendous amount of activity. Our brain gets really excited or really concerned if we could have something really good or really bad happen to us right now. When we think about other people, it's these gray and blue lines. We see a significantly reduced response. The brain is not as concerned, unfortunately, if other people are going to win the lottery or if other people are going to have bad things happen to them, whether it's right now or it's a month from now. What was really interesting and really started the movement around this, everything we've started to learn about temporal discounting, is when we think of ourselves in the future. And that's the green line. If you notice, it follows the same activity path as a stranger. And what we started to learn was that when you go out in time, your brain starts to discount the value or assigned impact of something positive or something negative. And your brain thinks of the future you as a complete stranger. So you think of why we wouldn't go walk into traffic right now, but we might smoke or not exercise or not do things that could have long-term consequences. It's why we would buy a lottery ticket, but not necessarily save for our retirement. A lottery allows us to win right now. Retirement, that's future me. Them not having money is a stranger not having money. And this is important because so many educational and treatment approaches have been based around educating on the pros and cons of what will happen if you get sober, or what will happen if you go use drugs. You know, this will happen, or you won't go to college, you won't do this or that. When you're making those interventions with adolescents, you're describing consequences and rewards that will happen to a stranger. An adolescent and an adult, really, are really interested in what are the benefits right here and now, and being able to present them with immediate benefits and immediate results is critical, especially when you have a very short window of time that you're trying to work with. Another thing we don't pay attention to is behavior change. You can use punishment, rewards, the presence and absence thereof. Positive punishment is the most effective at changing behavior the quickest and sustaining it for the longest. And for whatever reason, we are determined to use punishment over and over and over again. We have detentions and ISS and write-ups and all of these different interventions. You see them throughout treatment centers as well. There's no research that supports that any type of punitive or consequential thing is necessary. And we built treatment models that had no consequential or punishment systems there. Now, obviously, we put measures in place if something was dangerous, but most behaviors that people are responding to, nothing is dangerous. It's simply making people uncomfortable or is undesired. When we do change behavior with punishment, you tend to increase both anxiety and aggression. You think of the dog that you've trained by giving treats, positive rewards to sit, versus the dog you've trained by hitting. Those dogs have very different personalities because of the way that their behavior has been attempted to be changed. One is much more likely to change fast and sustain it. We talked about the neuroplasticity of the adolescent brain. It has the ability to rewire around substance use really fast, but it also means it has the ability to rewire really fast. Adolescents have an underdeveloped prefrontal cortex, and I can't tell you how many times adults forget this. If you are trying to use pure ration with an adolescent, you are trying to engage in a conversation that their brain is not capable of engaging in. It is not a lack of willingness. It is not an attitude issue. It's an inability. And you've really got to be willing and able to meet them where they're at and recognize that they don't have the same tools that you have. Think back to the choices you made at that age range, and the outfits and music choices and dating choices and all those things that seemed rational at the time that looking back don't now. That's what we mean by you'll understand when you're older. We don't mean you'll go through different life experiences that change your opinion. You have a brain capable of understanding things when you're older. Um, Reward centricity and attenuated aversions. Adolescents have a stronger response to rewards than they do aversions and negative things. So they're more prone to go to drugs because they hit harder for adolescents. The sex is better, the drugs are better, all of the dopamine releases are better, and the aversions are limited. And we typically think of this as a positive thing through the sense that adolescents are resilient and they have the ability to push through challenging times. But resiliency can also be a risk factor, because if there are natural cues that are trying to provide a consequence or an aversion and say, hey, don't do this, this stove is hot, as an adolescent, you have the ability to attenuate and shrink that down. It's not that hot, it's not too bad, it's no big deal, and continue engaging in something where there might have been cues to potentially stop. And then late addiction, we see hypofrontality. Addiction actually starts to shut off the prefrontal cortex to where people can't use that part of their brain. And I think a lot of the stigma and misinformation around treatment approaches, we replace that can't with won't. These adolescents won't think things through. They won't think of the consequences. They won't be respectful, and not realizing that they're in a stage where they can't. And your treatment needs to be based on that understanding that they can't. And then anhedonia is the inability for them to produce or process pleasure. So this idea that they're going to come into treatment or an early recovery, be in a great mood, is highly misinformed. It gets worse before it gets better as far as the dopamine cycle. You've cut off the only source of dopamine that they had. And even when they do produce it naturally, they can't process it or feel it in the way that they should. So just how bad is Texas when it comes to this moral model? These are actual therapeutic guidelines for how to work with kids in a therapeutic community model in the Texas Administrative Code. It says that it is intended to treat criminal and antisocial behavior. So immediately our legislation labels kids as antisocial criminals. It says the social and psychological characteristics of the client are to be changed to right living, and the client must adopt appropriate morals and values. So it's basing on an assumption that these kids are immoral and don't have values, and someone out there is the holder of what it means to live right. It encourages confrontation amongst clients, which, as we talked about, puts you right into fight or flight and is the worst thing we can do for causing or exacerbating a relapse risk. It even states counselors are there to act as role models and rational authority figures rather than as counselors. Because if we've worked with an adolescent, we know if there's one thing they love, it's an authority figure. And then this last thing is a really long disclaimer from a DSM we're not supposed to use anymore that has the access system that says if they have mental health conditions, which is about 90% of adolescents in residential treatment do have co-occurring mental health, they shouldn't come into this type of setting. So they're saying that 90% of the population probably won't benefit from this approach, but it's still what we encourage people to use. So what do these systems result in? Well, 46 plus million Americans in the last annual study met criteria for substance use disorder to the level in which treatment would be required. They're still closing 2022, so this is 21. Only 6.8% of those that needed treatment got treatment. When you look at kids specifically, it was only 3.5% that were able to access treatment, that needed treatment. So let's put all these numbers together. About 2 million of those 46 million individuals that need treatment are adolescents aged 12 through 17. And only 70,000 of them are going to get to access treatment. National completion rates for treatment are less than 35% on average. We tend to not successfully complete around 7 out of 10 of every individual that gets access to treatment. And then we see relapse rates in the range of 40 to 60% of within 90 days returning to use at the levels that it was prior to treatment. So returning, not staying in remission, returning to use. So we start with the entire population of 3 states, Alaska, North Dakota, and Wyoming, worth of kids that need help. We get the population of North Richland Hills, Texas, kids that get it. Houston soccer stadium attendance worth of kids that are going to complete. And a small Friday Night Lights high school football stadium game in El Paso worth of kids that didn't return to use. So we go from 3 full state populations to a high school football game in El Paso. We have a 0.5% success rate when we break it down for kids. I can't think of any other industry would be okay with that, where you'd go to a heart surgeon who says about 0.5% of the time I do this successfully, or a mechanic that says 99.5% of the cars I work on never drive again. But this is the industry and the outcomes that we've got for sons and daughters that are being handed over to a treatment industry during a time where we need it to be more effective than ever. So we really do need to pay attention to this playing. We do really need to figure out a different way to go about it. The first thing I urge everyone to do is recognize everyone with a substance use disorder has a good goal. I have never worked with an individual where they didn't have a good goal. We get distracted by the means. A lot of times they're trying to reduce stress, alleviate anxiety, cope, a trauma response, all those things we talked about. Maybe they just they're saying they want to go out and party and have fun, or they're trying to make friends in a new environment, or they're trying to relieve physical pain, not just emotional pain. Or maybe we have a young adult misusing amphetamines and Adderall in an attempt to study for an exam. At the end of the day, those are all good goals. I can't think of anyone that would be upset that someone wants to do well on tests, that wants to have friends, that wants to have fun, that wants to feel good. We get so distracted by the means of what they're doing to accomplish it that we forget there's a really healthy goal down there. By taking away the substances, we haven't taken away a problem, we've taken away the attempted solution. And we haven't done anyone any favors if we haven't identified what the actual goal for that individual is. And it's going to be different for everyone, and figuring out what it is they're after. If anything, you're causing harm when you take away just the coping skill that they have. If you don't put something else back in its place, they've just lost their attempted solution of what they were trying to go after. So don't get distracted by the means, and see if you can work with individuals to get to what the underlying issue is. So many people are familiar with the study of learned helplessness. And I'm sorry, this photo has the world's cutest dog in the world. I couldn't find one, but if you know the study, you know it involved small shocks to the dog. And what it was is a really famous study that they still teach in counseling programs. They still teach the teachers, where basically these dogs had 2 puzzles. One, they were on a shock pad, and if they hit a button, it would turn off. For one set of dogs, if they hit the button, it would stop. For the other set of dogs, it didn't matter if they hit the button or not, it would keep going at random times. And then they put them into this second puzzle that you see here, where if they hopped over the box, it would stop in the middle. The dogs where the button worked solved this problem right away. They hopped over and the shock stopped. The dogs that didn't have a working button, and the ones before, when they got shocked the first time in the box, time and time again, they just laid down and they just took the shocks and they would just give up. And introduced this theory that you learn to be helpless, that you would learn to not try and not push forward if you went through these experiences. Well, Dr. Seligman actually went back and revisited this study once we had the ability to do brain imaging. And what we found out, and for whatever reason we continue to teach learned helplessness, was that the theory was wrong. What had actually happened when they studied brain responses and targeted different parts of the brain is that helplessness was the default. And that when the dog that hit the button and it worked, a different circuit in the brain between the medial prefrontal cortex and the DRN was activated that then would work again in future situations. And he named it the hope circuit. So what he actually found was the dog wasn't learning helplessness, it was learning hope, it was learning optimism, which are 2 of Dr. Seligman's books that he wrote, The Hope Circuit and Learned Optimism. So we stand a lot to gain, not by looking necessarily back to the problem, but how do we instill hope and create manageable, solvable, step-by-step problems and solutions for people? Because once that hope circuit gets activated, our willingness to engage, to demonstrate resiliency, to persevere is on a whole different level. But a lot of what we've done, and it has been built upon a misunderstanding of what was happening before. Another example I want to talk about, in positive psychology, there's a tremendous amount of work on happiness and well-being. And Dr. Lubomirski does a ton of research, and she's since updated, but she overall categorized happiness and what creates well-being in individuals into three main categories. She found that about 50% of it was genetically predetermined. People either had happy genes or didn't, and had their mom and dad to either thank or be frustrated with for it. But little to no control, kind of stuck with what you got at that point. About 10% was due to individuals. The variance between people was due to their life circumstances, their marital status, their job, their income, their car, where they lived, things like that. And then 4 times more powerful than that was their personal outlook on life or intentional activity that they took. So we are not in a place yet where we can go and change our subjective well-being genetics. So we're kind of stuck with either trying to change our life circumstances or our outlook on life. And more often than not, we put a disproportionate amount of energy into our life circumstances. We try to get that new thing. We try to get that raise. We try to get that status. If I can just do this, if I can just get to the weekend, if I can get whatever it is, when in reality, we have 4 times the impact by changing and adjusting how we choose to look at things and taking an intentional activity steps and interventions with ourselves to work on those things. So we stand to gain when we work with kids and individuals to focus more on outlook than outcome with some of these different things. I'm going to show a video and then tie it back to this. The video is not related, but it perfectly ties in. It was related, but not on purpose. There's these 2 monkeys, and they were trained that if they handed a rock to the researcher, they would get a cucumber as a reward. And for the first time ever, they start giving one grapes instead of cucumbers, which they like a little bit more. So we'll walk through this after watching it.
No monkeys who never done the task, they just say that they would have a stronger reaction. That turned out to be right. The one on the left is a monkey who gets cucumber. The one on the right, the one who gets grapes. The one who gets cucumber, note that the first piece of cucumber is perfectly fine. Then we see the other one getting grapes. So she gives a rock to us, that's the task. And we give her a piece of cucumber and she eats it. The other one needs to give a rock to us. That's what she does. Gets a grape. The other one sees that. Gives a rock to us now. Gets again cucumber. The rock now against the wall. And she gets cucumber again.
All right, so we can't really have an open discussion, so I'll kind of discuss it with myself how we normally would when we talk about this. But you walk it through, right? Monkeys, he's giving a rock, he gets a cucumber, totally fine with it. Other monkey gives a rock, it's great, fine with it. Then he gets a second rock, gives cucumber, throws it at the instructor, banging on the cage, gets so mad. So let's think about that through that lens. Was there anything different between the second cucumber and the first cucumber? No, it was the exact same situation. It was the exact same circumstances. When we talk about our circumstances, I give a rock and I get a cucumber, and those are my circumstances. So how can you have pure happiness and eating up this cucumber immediately to pure rage where you're throwing it and banging and making all this kind of fuss about everything that's going on? Well, their outlook changed. Before, I compared the cucumber to the rock, and this was an upgrade. I was doing a comparison. My goalpost was below what I had, so it was a win. After seeing the monkey get a grape, the comparison point is most likely to have changed to now I'm comparing it to, instead of this cucumber being better than a rock, it's not as good as a grape. And this effect will continue whenever your outlook is ability to have that. So when you go after trying to change your circumstances, what we find is you get a very brief honeymoon period. Hedonic adaptation sits in, and now all of a sudden that thing's not enough. The grape needs to be a banana. The banana needs to be a banana split. The banana split needs to be a milkshake and a banana split. You will always find that. If you don't learn to experience happiness or well-being with what you have in this exact moment, odds are you may not find it, because if you're dependent on circumstances changing, you will always be dependent on circumstances changing and how to find it. So obviously these types of theories and interventions expand well beyond substance use disorder treatment to just all individuals and communities at large, but being able to take the time to focus on outlook and help people with changing outlook and not circumstance. And then I talked about wanting to emphasize empathy. So hopefully the information I've given around the barriers to treatment, what adolescents are up against, and everything you've learned today can help you create a sense of empathy for those that are dealing with substance use disorders, especially adolescents dealing with substance use disorders, what's going on in the brain, what's going on in their bodies, and all the different challenges being faced. So it turns out in treatment and outside, empathy is the most important thing. It turns out it's the top predictor in effectiveness in treating substance use disorders is the therapeutic skill of empathy. There was 25 to 100% variance in successful outcomes correlated with empathic listening in sessions. What this means is they did this long comprehensive study, and then one of the variables they ranked was the therapist's empathic listening skills. When they looked at the therapists that had the lowest scores of empathic listening, their clients had been completing at a 25% success rate. So 3/4 of them wouldn't successfully complete. When they looked at the therapists with the highest empathic listening scores, they completed 100% of their patients throughout the entire duration of the study. The more empathic and client-centered the counselor style is, not only do they do better in treatment, but the relapse risk goes down. It's one of the strongest correlates in 2 years post-treatment with whether or not that client is still in remission, is still sober and not having continued substance use, was how well their counselor listened to them during the intervention period or the treatment period that they had. And when we say better, 1/6. So you're 6 times more likely to have a relapse when working with a low-skilled empathic listening counselor 2 years later. That's how long this is. It's not just something that helps in the moment, but it's something that's shown retained remission, retained success, and benefit for patients when it's utilized in sessions and interventions. Turns out that empathy is a better predictor of sobriety than the client characteristics or the treatment methods used. They did Project Match and all of these other studies where they're trying to figure out is motivational interviewing, 12 steps, CBT, DBT, which approach is best for substance use, or which of these approaches, if you pair it based on certain client characteristics, is better, or is graduate level versus associates level counselors better, or do we see disparities between race, gender, demographics, or the substances that patients use? All of these studies, empathy wound up being the biggest predictor in success, regardless of the approach the therapist used, regardless of their credentials, gender, demographics, education, and experience. If they were able to demonstrate empathy, they had the best outcomes. And then very scary, clients treated by counselors low in empathy tend to have worse outcomes than the control group. So not only when you work with clients not from a non-empathic stance are you not helpful, but you're actually actively harmful. They had 5 times higher relapse rates when they had to work with a counselor that was low in empathic listening than when they got to work with someone who was skilled in empathic listening. So we make the issue worse, which goes right back to that plane. It is continuing to pile armor on the bullet holes where they're not supposed to be. And we think we're benefiting and we're making the problem so much worse. And so many treatment and so many interventions, whether it's in school systems, home systems, are centered around a lack of empathy and understanding of what someone's going through. It's a lot of telling people instead of asking. It's a lot of threatening and using punishment instead of reward. It's a lot of misinformation and bad practice that there's no real evidence to support it, but for whatever reason, we continue to be drawn to it. And that is the end of my presentation. And then I can open it up to questions if anybody has any.
If you want to put your questions in the chat or raise your hand, we're certainly able to help you. And thank you, Drew, for that amazing presentation. Kevin was asking if he could get copies of some of the slides in the presentations. He really found it amazing.
Sure.
And Michelle's got a question.
People can email me for it.
There we go. And Michelle, I'd like to know if you're familiar with the harm reduction works and are there specific meetings for adolescents?
I'm not familiar with them. I'm familiar with some other harm reduction initiatives, but guessing off the name, anything that's promoting harm reduction, I think is incredibly valuable, especially for adolescents. There's a lot of resistance to providing Narcan or Narcan to youth, and people not research shows nothing but harm reduction strategies prevent deaths, prevent spread of, STIs and STDs and health issues. When we talk about, needle-based use, crime rates go down, and it doesn't increase use. So that would be, I'm sure it's a great initiative. I'll definitely look more into it, but I'm very pro harm reduction. And I think it's one of the biggest reasons the U.S. has been lagging in these outcomes is our slowness to add those.
Any other questions? Let's see, there might be one in the Q&A. It just says, any chance Phoenix House will reopen the residential programs?
No, I would hope so. We're really dependent on what the government funding is going to be willing to provide, because there are resources for individuals with insurance, and we were really aiming to be that resource for those that don't have private insurance or don't have the ability to pay for their treatment. So we're heavily dependent on government contracts and grants that help cover some of those costs. So we would love to, but we've got to make sure we've got a sustainable model in Texas in place. But certainly cause for concern as those adolescents then can wind up with overdoses in the criminal justice system, which is not beneficial, and a variety of other negative consequences.
And then for those that are wanting the presentation, we'll make sure that Michelle and Drew's presentations are shared with you along the evaluation link. So you will have all that being sent to the email that you provided.
Looks like there was just one comment in the Q&A. Maxine said that she had a work coach early in her career that clients don't care how much we know until they know how much we care.
Mm.
Excellent slogan to go alongside with the empathy, and in practice it winds up being very true. If that empathy is not perceived, patients tend to not progress.
Absolutely. Lots of thank yous in the chats. Drew, you did a great job.
Thank you.
All right, I think we can start with our panel. Agent Sparks was not able to attend for the panel portion, but I think Cynthia is here to answer any questions that any of the questions that pertain to him, she may be able to answer in the chat. So, Rebecca, if you want to start.
If you guys have any questions for Drew, Michelle, or Cynthia, they're all available to answer any questions you may have.
we have a couple starter questions that I have for both Drew and Michelle. And then as we get the conversation started, if anyone wants to pop something in the chat or the Q&A. But the first question is, how can we break the stigma on our school campuses?
I can start and speak a little to that. I mean, to me, I think a lot of it comes down to the language and responses used. I think the classifications, the words that you use, being really mindful of it. NIDA and a lot of other organizations have really good guides for some of the words, that you shouldn't use and can replace it with. I think that can help. And then also how, administration and policy, is it centered around providing people treatment, or is it centered around providing people strictly punishment? If someone's caught under the influence or with a substance, is our reaction only punitive in nature, or are there resources that are being offered as well? And I know a lot of that is outside of maybe a teacher's or direct staff control, but I think the more that we can work to provide an appropriate treatment response instead of just doling out consequences, we can really start to make a difference on campuses.
I want to say that I agree 1,000% with Drew. I used to be a crisis counselor at a high school, and I will tell you that one of our how do I say this, guiding principles at our place, and I'm sure Drew has the same thing, is that we are not punitive based at all. We are very much relationship based and empathy based. And so, Drew, I just adored your presentation because it just spoke to me so much. But I will tell you that it was funny. My brother, when we had that conversation about starting something, he said, you cannot have it be a punitive based program, because if we knew how to follow rules, we wouldn't be in the situations we're in. And it's so simple to think about that, but it doesn't work. And so I get it. I get the schools have to do that. But I think we also, as teachers, it's going to start from parents, teachers, assistant principals, you name it, coaches. It's going to start about seeing past the behavior and looking at the why and having that empathy. And like the girl said, the lady said earlier, we feel like we take it personally because we can't change their behaviors. It's hard to change their behaviors, but if you can really push yourself and be convicted about getting to the, what do you need? I know you've been through so much. What can we do to help you? That is really going to be there. I don't think there's anyone on the planet that's going to be like, oh, thank you so much for bringing my behaviors to my attention. If somebody would have just told me, I would have changed. So thank you. I'm going to completely be fine now. Nobody does that, right? So I agree, Drew, 1,000%. We have just really got to figure out how to reach them from a relationship level than more than punitive. It's just not going to work.
So another question that we have is, how do you talk to a parent when you think their child may be dealing with substance use or abuse?
Well, Drew, if you want to take this, I can too. I just, by the time they get to us, so it's funny because we do pre-admission assessments with the parents first, and they'll tell us how much they think their child is using. And then we'll talk to the child and they'll tell us how much they're actually using. And then we get them in, and then we find out that's what they're really using is 10 times more. So there's different levels. But you have to be careful when you talk to parents, and many of them, they have rose-colored glasses and that kind of thing. But really it's about okay, is this working? Is your life working? Is your child's life working? How's that going? Are you noticing these things? We always want to empower the children to be the ones to tell them, to be honest. That's what we want to do, but it takes delicate but hard and real conversations, because what's our goal? Is our goal to be a friend with the parent? And I always tell them that. I'm like, I'm sure you're a super nice person. I'd love to be friends with you, but at the moment, I just want to keep your child safe and healthy. And so I need to share this with you. or I really need to encourage your child to share this with you, or I would really like for you to sit down and have a conversation with them, and this is what that can look like. So I always am in favor of communication and transparency.
I agree with everything you said around, being able to figure out what works for that individual family and those people. I think, this is always the question that everyone wants, what's the most effective way to handle this, or how do you do this? But I think the minute we come up with one answer, we start getting prescriptive and ineffective. So I think being able to be mindful of what are the best approaches and figuring out what works for this family, what their unique strengths are, what their goals and motivations are. A lot of family dysfunction, substance use can look the same, but the motives, the why Michelle talked a lot about can be very different. So I think making sure we really get to the root of what their needs are and their specific situation. So it's more like carrying a set of principles than the actual intervention. I think that that's going to be unique to every family you work with.
Yeah, absolutely. It's kind of a delicate walk there.
I just want to tag onto that and just be like, I know when I had to, call a lot of families when I was at the high school, I would always just say, hey, I'm here to help you. I'm here to meet your family where you're at. I want to provide resources. I want to provide help. I'm not the your kid's a bad person, you're bad parents. Like there's no blame and shame. It's really like, how can we help you? And so if you come at it, like Drew has talked about this whole time, from an empathetic standpoint, even with the parents, you're really not going to have many that argue with you. Like they're going to basically fold and be like, how can you help us? What can we do? So I really think it's the approach is a big part of it.
So another question is I got one in the chat right now. For Michelle, how often do girls not complete the program and or have to be readmitted? And readmitted, do they start it over again?
Yeah, that's a great question. So I will tell you that when the girls come there, it's funny because parents think, okay, they're in your doors, they're safe, they're not going to cut anymore, they're not going to like, and I see Drew shaking his head, so he sees this too. But and we tell them, look, they're coming here. We are taking all of their coping skills away, basically, and we're starting fresh with new ones. So they're going to do whatever they can do to control, which is generally harming and restricted eating. Those are the two things they generally can control. And so I'm saying that because there are times that we have to, and we can deal with that while they're there, but there are times we have to send them to inpatient to get stabilized because they'll have either maladaptive suicidal threats, or they'll have actual suicide attempts while they're with us, or the cutting is so bad that we have to send them places. So I will say that while they're with us, there are many that we have to send to inpatient, and then we get them back and, we continue with them. It's just part of it. There are some that we have to refer out to longer and or higher levels of care for a more intense time. There's probably a handful of those. I will say that us particularly, we tend to stay with them a little bit, probably more than most, or that we should, because we really want to get past the behaviors to get down to what the issues are. And so we try really hard to stick with them, but sometimes it's like we can't keep them safe. I will say too that there is a direct correlation to the parents' willingness and engagement and being willing to be agents of change and the outcomes of the girls. So when we have families that are not, they're like, this is my child's fault, this is not an issue with us, those are difficult. And we are very unapologetic and intentional about really, really holding the parents accountable and really working with them to be agents of change. And that doesn't mean they're terrible parents. It just means like, let's learn some new skills, tools, communication, like, and so when you asked how many complete the program, I would say we have about And I will say that insurance is a big factor. Andrew, I know you know this with the funding situation. We are an out of network provider, so there are some policies that pay the whole entire stay, and there are some that pay a very tiny portion. We are constantly doing authorization reviews. Our medical director does peer reviews, all of that. We get them as many days as we can. So sometimes it's a financial issue. Generally, we try not to let that happen. But I would say our completion rate is probably about 80%, which is really good. But, there are factors that really are kind of out of our control. And then we also have a really strong alumni program. So we try to really help them after they leave us to make sure that they are still, we have groups, we have support systems, we have all that stuff like afterwards, because we know that recovery is longer than 3 months, right? And so we have had 3 girls that have completed the program and come back because of relapses. And I will tell you that their addiction was at a point where they needed just further care. And their families also, we have girls. I will tell you the story. We had a girl that she was here with us for 120 days. She was 14. Her mom, CPS had been done like 6 investigations on mom. Mom didn't want her back. Dad was incarcerated, in and out of jail. And dad was the only one that actually really did the family program with us. The sweet girl was 14. We had to let her go at that point to dad. And dad gave her pot on the way out of our driveway after 120 days of treatment. And so when we're dealing with families like that, it's just really hard. It's really hard to have positive long-term outcomes on those. So yes, there are a few that come back, but there are some that go into, longer term treatment. But for the most part, 90 days is a really good start. And if we can get parents on board, it can be really successful. I think Drew would probably agree with the parent part.
Oh yeah. Well, in speaking to the relapse, like relapse rates for substance use disorders we think of them so differently. Like if someone is treated for asthma and starts having asthma issues, that's a relapse. Or if someone's medical conditions flare up or their depression returns, we tend to be very black and white and label a relapse as lack of success, when there's been harm reduction, there's been reduction in use. So I don't think it's necessarily fair to think of patients readmitting as like a failure. If anything, the fact that they're willing to reach back out, re-engage in a program means that they know how to utilize those skills. Because we don't do that for other, people who are having issues with their diabetes or cancer that returns. The technical term still there is relapse as well. So if we truly do keep that in the same category, it's very normal. It's just with fentanyl and overdoses, it's just become all the more significant because they can be so fatal now when they happen, at a level we've never seen before.
I agree. And I just want to add on to what Drew was saying. We also agree. We tell parents and girls, you are going to relapse. It is very high likelihood that you are going to relapse. Now, that doesn't mean you're going to fall off the wagon and use a lot, but you might have a behavioral relapse. You might have a fight with your parents. You might use again, but it's really about like, how do you work through that this time? What does it look like after your relapse this time? And so I agree with you, Drew. Like it's I always tell them, you didn't fall off a cliff. You just like misstepped a second, but you're back on the path. And what are you learning from that? So I agree with that.
So another question would be, what are some interventions that schools can implement with some of the current resources out there?
I'm going to lean heavy on empathy-based research. Dr. Okanofa he worked with a school district on cutting down suspensions, and he taught teachers empathy-based classroom redirection versus traditional classroom redirection. And across ages, genders, and racial differences, the students had suspension rates that were half of what they were before. Then he applied it to one of the highest recidivism rates is youth returning from jail into a public high school, of how likely they are to return back to jail because of how uncomfortable that setting is. It's about, I think it's like 79% of them wind up back in jail within the year. And he did an empathy exercise with the teachers where he had the students write a letter about everything they were feeling about coming into the classroom and all the emotions they were going through, worried about what their peers would think, this, that, and the other. The teachers would read it, and they cut the recidivism down by 30% just by informing the staff these kids would be working with, of providing a sense of empathy, like, oh, this isn't what I thought, this bad kid coming from jail who's going to be trouble. They saw the worries, the fear, the anxiety, all of the emotions that they were going through and coming back. So long story to just say any way to incorporate empathy-based classroom management and things like that is always proven to be really successful.
Yeah, and I'll add on to that too. I don't know if Cynthia's on here, so I don't want to take her time if she's here, but I also would say that I think the way that I think Drew said it in his presentation, that people are forgetting that they are just unable. Our adolescents are just, they do not have the ability to reason. Like, they don't have the ability to manage their behaviors. And so if you're thinking about it like in a classroom setting, most of our kids are just heightened. Most of our kids, their amygdala and their limbic system is just really heightened. And I always tell teachers, I was a teacher too, but I always tell teachers, try to bring them, if you're looking for like an immediate intervention, like try to bring them to their cognitive place, try to bring them to their frontal lobe. So I always love doing like, would you rather questions? Would you rather have your one eye vertical or your nose horizontal? Or like, give them a little tiny word search, or like get their brains up here, get this part working, because then that will decrease what's happening in their emotion central. So that's a quick intervention. But as far as interventions, like in general, I really think it's going to be kind of along with what Drew's saying, is just empathy-based approaches, but we're really going to have to target the families a lot, because I think the parents and the families, I can't tell you how many people they call us. The girls have been running away. They've overdosed. They've, had these really high risk sexual interactions or online relationships. But maybe if we just have a really nice Thanksgiving with our extended family members, that will help. Or maybe if we just take them to Mexico for like a week, it'll just help them. It's just the families are not understanding that, like, you have to be on this and you have to remember your role. I think the parents are kind of like having role confusion, in that they're not being the parents that they need to be, as far as like making sure that they intervene too. Because you can't leave it up to the teachers. You can't leave it up to the administrators. You guys, they're working their asses off just trying to teach and do what they have to do. So it takes a village for sure.
And when would you suggest that we need to report like substance use to guardians or the nurse, or even like public, like the SRO on campus?
I mean, I guess from a high school counselor standpoint, my litmus test was always that if they were currently impaired and it was affecting their functioning and their health and safety, then I would make sure that I would report it. I would generally really try to have them do it, which sounds crazy, but you'd be surprised how they could be willing to do it, because I think that really empowers them and gives them some control in the situation. But if it's going to impact their health and safety, and if they're not functioning properly, then I would report it to probably their parents first. Yeah. that would be and that was what I was mentored to do. Like, it's always about, if you hear that someone's using or somebody says they've used. As a counselor, I will never forget this. I did my internship at DAP in Louisville, and I had a student, this was years ago, and I had a student that had taken like 8 Xanax over the weekend and didn't really remember his weekend. And I remember my mentor telling me, my supervisor said, you really just have to meet them where they're at. And I was like, okay, so maybe this week you could just take 7 instead of 8. Like, I just remember, like, you have to meet them where they're at. And he wasn't currently using, but I know that affected his safety at home. And so, like, that's really your litmus test, I think. And as far as CPS reports, I know I've always learned that, if you're on the fence, then you need to do it, because there's no really over reporting to CPS. I know that they're stretched, but I always think if you don't report and God forbid something happens, then that's on you, and that's not okay. And so it's just, if there's ever a question, I always err on the side of caution and just go ahead and report it.
In addition to that, there can be other, children in the home or even younger kids. A lot of times, use in the home can be different if there's, a 2-year-old there, a 3-year-old there, or other circumstances. So it might be impacting more than just the child in question. It could be even friends or other people that are potentially in danger as a result. So it's always certainly better to call. You don't know who all could be affected or what more could be going on. And it's better just be safe.
Absolutely.
Okay. So what are some safety measures that we can put in place in our schools, churches, and homes to kind of support, maybe individuals struggling with substance use?
I think in addition to a lot of the practices we kind of already talked about is, having some harm reduction materials like Narcan and things like that are really good resources to have. And the amount of districts or universities we've gotten, pushback from, I use that metaphor, like they have fire extinguishers and all of these other harm reduction things around that they don't worry are going to promote fire starting or, heart attacks because they have an AED. Narcan should be thought of in the same lens. And statistically, that's infinitely more likely to be the cause of a student death than any of those other things that they do have on the walls and readily available. So I think making that as available as possible, making sure people know how to use it as well.
Yeah, and I think I would add that, idle time is one of the factors that increase substance use and unhealthy behaviors. So I would say making sure that they have plenty of opportunity for community involvement, activities. I know that our schools have so many things they can be involved in, but really encouraging families to make sure that these kids get involved. Like, going home and sitting on social media for the next 6 hours after school is just not, it's just not effective. Also, just increasing their support system. What is their circle of influence? Is it coaches? Is it teachers? Is it counselors? Is it parents? Is it an aunt, an uncle, a neighbor, a spiritual leader, anyone like that? So making sure that they have a strong support system is a good protective factor for them. Also, I know that when I was at the high school, they started kind of really teaching coping skills, which I know all the kids are like, oh, coping skills, I'm so tired of hearing that. And teachers are like, I'm not equipped to teach coping skills, all of that. But they really do need to learn those. And the more that they can be exposed to them and put in front of their face and practice them is going to be good. And then, of course, like Drew said, just empathy. They just need people to care about them. And I agree with all the statistics about the counselors and if they are empathetic, the success rate. But I think that goes for anybody, friends, peers, teachers, anybody. Just showing that care and empathy is going to go a really long way.
Wonderful. And if we have any more questions from anybody still in the audience, if you guys want to put that in the chat, we will be able to answer that before we talk about the closure of this session. Then Maxine put in there, I was talking with someone yesterday who said that the non-medical individuals are not administering Narcan due to liability issues.
I think everyone's working to get kind of a good Samaritan laws in place and make sure people are protected in that regard. Same thing with like that they protections offered for issuing CPR and things like that.
I saw that there was a question in the Q&A about TBRI approach. I love TBRI. I think it's absolutely an excellent approach to use, because whether you're working with a 5-year-old or a 15-year-old, to just kind of get down on their level, stay calm, ask what their needs are. It's just such a good form of communication, to just say, tell me what you need right now. Like really calmly look in their eyes and say, tell me what you need right now, because you're not attacking. So yes, we didn't really talk about it, but I absolutely love the TBRI approach. No doubt. But like Drew said earlier, like there's just not one prescription. I mean, there are so many approaches you can use for these kids, but it truly all comes down to just being relationship-based, empathetic, and caring about them, really.
Okay. Well, I want to thank all of our guest speakers for today, Agent Sparks, Cynthia, Michelle, and Drew, for the wonderful presentations and staying on for our panel discussion. I really appreciate that. I also want to thank everybody for joining us and who was able to participate in our discussions. It was obviously a very well collaborative conversation, so I definitely appreciate that. We appreciate everybody being here, but before we end today's Watch Wellness Workshop, I'd like to talk to you for a moment about the online evaluation we mentioned this morning. Please take a moment to visit the link on your screen before leaving today's event to complete the evaluation. Please make note of the email you are using when you're filling out this evaluation. When you submit and complete your evaluation, a CEU certificate will be sent to that email address that you've entered, so you can access it and print it later. And please know that we take our feedback seriously, and we use it to help plan other topics and line our guest speakers, themes, and format for all future workshops. We ask that you take a moment to complete the evaluation now. We will notify everyone when this recording is available on our website to be able to share with anyone you think that may want to view this workshop at a later date. And we will keep this Zoom session open until around 2:45 for allowing for any network that anybody would like to do. And please feel free to use any information about your organization in the chat. This can include the name, the type of population you serve. If there's a resource or connection you're interested in making, please use that chat box for that networking opportunity. And again, thank you all for spending your time with us today. And I hope you all have a wonderful afternoon and enjoy this amazing weather we're going to have this weekend. Thank you.